you both bring decades of expertise to this discussion, so I want to tap into that with my first question. Given all that you've seen and heard over the years, compared to what you're seeing and hearing now from the public and politicians, do you think we've reached a place, say a new normal, where the country is ready to seriously and critically consider universal coverage?
Grace Marie, want to start?
I don't think we're there. I think that universal coverage as a concept, absolutely. But the question of how you get there, I think, is so polarizing that we really have to have a national debate about whether or not we do it by really making the market work so that the structure that we have of employer-based health insurance, Medicare, Medicaid, the subsidies through the ACA work better for people, or whether or not we say, nope, that whole system's not working. We really need to move to a much more government-centric system. I think that's really the debate. I've agreed for a long time. We want to make sure everybody has coverage, but how you do it is, I think, where the polarization is.
Andy, would you agree with that?
Yeah, well, certainly, even though you said no, I do agree with you because I think the public over the last 5 years, I think is pretty significantly cemented its view that everybody should be able to have coverage. And if you put aside the political words we use, universal coverage, Medicare for all, market, not market, whatever, you just put all that aside, and what people want, I believe, is something that's quite simple. If someone in their family's sick, they just want to be able to afford to take care of them. Period, end of story. And they believe that should happen for everybody in this country. Now, if that is we should not just brush aside the fact that is a movement that has happened over the last few years. And the reason it happened, actually, I think has actually less to do with the ACA and more with the effort to repeal the ACA, which I think made the country realize that they were in danger of losing something that was quite valuable and quite existential to them and their families. So now off to the question of how, hundreds of ways, lots of ideas. I don't think any one of us for a second should think that you make one decision and say, this is the way we're doing it. If you look around the world at people who provide universal coverage, there's literally hundreds of decisions having to do with how do rural hospitals get impacted, physicians, specialists, and the lot. So if we get into that debate, I think we'll find that there's nuances, but they're all in the same direction.
You just recently testified before Congress on these issues. And I want to ask you, as the ACA becomes more popular, do you think there's still a conservative case to be made for replacing and repealing it? What's the conservative alternative?
Certainly nothing's going to happen in the next 2 years. And in Congress, as far as any major sweeping health reform, I do think that Congresswoman Underwood is right, that there are some specific things that can be done. But I think that we really need to look at how do we give people more choices and more control. She talked, and one of the things I testified about was this short-term limited duration plans. The Trump administration has been trying to give people more choices through its regulatory authority. People who are between jobs, early retirees that don't yet qualify for Medicare, some of the people who need this bridge coverage, 3 months is just not enough, and they need longer coverage. And I actually had a broker write to me after my testimony. He said, these plans really are valuable. I had a client who had been receiving subsidies through the ACA. His income increased, so the subsidies decreased to the point that he couldn't afford the coverage. So he bought a short-term limited duration plan. A short time later, his son was diagnosed with leukemia. Tragedy. But because he had bought this short-term plan, the plan paid $170,000 just in that year for his coverage so his son could get the care he needed. So I think that as we look at people who are suffering from the high costs, being pushed out of the market because they can't afford the coverage, that we need to think about what kind of options can we give them. Association health plans, I think, also are another option for people to get affordable coverage. So that's what we're looking at in the short term.
Andy, you were responsible for implementing the ACA under Obama. And as no legislation is ever perfect, what areas do you see that need improving as it continues to grow and evolve over the years?
Right. Well, so I was working in the private sector when the ACA launched. I came in to lead the effort to repair it, turn it around, and then ultimately implement it. And I would strongly encourage us to pay attention to the fact that we need to make sure that these laws work and that they work for people. I think the challenge, with the short-term limited duration plan, it's not the answer that people are seeking. It's not the answer that people are seeking because think about what it is. It's a plan that lets the insurance company decide who to cover, whether to cover them, how much to charge them, what to cover, and it essentially requires us to be smarter than the fine print, smarter than the insurance companies who write the fine print at reading the fine print. And that's been a recipe for over the course of time before the ACA, much more dramatic healthcare costs, much higher illness, many more bankruptcies. So, it's not where the solution is. Where the solution is, and by the way, everybody knows it, nobody's been willing to do anything about it, it would be to very simply take the things about the ACA as it passed, look at the things that worked, and look at the things that didn't work, and just improve the things that didn't work. The Republican Congress was unwilling to do that because they wanted it to fail. And so essentially the ACA has been frozen in glass. Everything that's worked is working, everything that hasn't worked has gotten worse. That's no way to run a country. That's irresponsible. So there's obvious things. There's a family glitch. The subsidy levels don't extend high enough, which is a point that you made. The ACA was done in a way that was created a budget surplus. If you had it to do over again, you would extend those subsidies to higher levels of income, because the only people now that don't get any subsidy from the government are independent businesses and people that are in the middle class. But what's missing, forget any one policy idea, is a commitment to work together to fix what this country has. And for people who aren't willing to do that, I would say that they have checked their patriotism with their party loyalty. And I will say the same thing to both parties. The Trump administration now is putting forward, I think, some very valid proposals around prescription drug costs. And Democrats who have long believed in those things should ask themselves whether they still can believe in those things when someone else proposes them.
Do you think they'll be able to find common ground?
Well, look,
on
the ACA
prices?
was an idea of private markets created by the conservatives. Now, it wasn't implemented necessarily exactly the way conservatives might have wanted it to be implemented, but that's where room for politics and policy improvement comes in. That spirit, as long as that spirit is gone from our Congress, we're not getting anywhere. The irony, of course, is, as Congresswoman Underwood said, that divide doesn't exist out in most communities in the real world. Most people are much more unified about what they want and what their perspective is.
One of the things that I think there hopefully can be some room for bipartisan agreement is the state innovation waiver in the ACA, that Section 1332, that gives states the authority to move some of the money in the ACA around to make it work better for their states. And there have been 8 states so far that have asked for these waivers, and 3 of them we actually have some data on that show they've been able to, by taking some of the ACA money and separately subsidizing the people who have the highest costs, who are often driving up premiums for everybody else in the market and actually shoving out the people at the margins, to be able to separately subsidize them to lower the premiums and bring more people back into those markets. So those are some of the state innovations that I think are working. Some Democratic legislatures, and I don't know any Democratic governors. Yes, Oregon has done one of these waivers. So I think there's already a bipartisan platform.
Minnesota, Oregon. Yeah.
Yes, to give states more authority so that they can fine-tune the resources that are there to make it work better for their markets. And I think that's something that's very strongly
Well, the state innovation waiver was in a law called the Affordable Care Act.
Yeah, exactly.
So it's something that was part of the plan.
Right.
And of course, for a long time, Republicans refused to use it because it was in the Affordable Care Act.
Well, it didn't start till 2017. That's the first authority they had to use it.
And then they refused to expand Medicaid because it was in the Affordable Care Act. There's a lot of, my point is not that somebody's good and somebody's bad. My point is that we get attached to these labels, and they allow us
Right.
to become to govern whether or not we do things that are quite sensible and we would do on our own. Now the question I think around the state innovation waivers is not whether we should do them. Of course we should do them. The question is whether or not the Trump administration will let red states be red and blue states be blue. When I was in the Obama administration, I approved an Indiana waiver, a Tennessee waiver, a Texas waiver, all kinds of waivers in conservative states who wanted to try out conservative principles. Were they necessarily things that Democrats would agree with? That wasn't the question I asked myself. So if the Trump administration is serious about really wanting to try state innovation, they will approve a set of waivers that come from blue states and from red states that allow people to try and see different things that work. And they'll do it with a set of safeguards that'll make sure people don't get hurt.
Well, speaking of President Trump, what do you all think of his tactics aimed toward Big Pharma at trying to reduce drug prices?
I actually think that this rebate idea, that it was really sort of pulling back the curtains in the Wizard of Oz on what's really going on in the supply chain in the pharmaceutical industry. And the drug companies say there's so many incentives, and everybody's saying there's so many incentives to prop up prices, to keep prices higher in order for the rebates to be bigger back to the companies and the health plans, or to the employers and the health plans. And being able to provide those rebates directly at the counter, yes, there are going to be some other distortions in that too, but the pharmaceutical executives that testified yesterday for the Senate Finance Committee all said, yes, we would lower our prices, but it kind of has to happen all together. Any one company trying it, there's just too much pushback. So I think the rebate idea is a really good one.
They wouldn't commit to doing it, though, unless it happened to employers as well, unless a rebate got passed through. So I think they left themselves a pretty big out.
I think there's going to be a lot of pressure. Once they do it for Part D and they do it in the Medicare Advantage plans, I think there's going to be a lot of pressure for that to move into the private sector.
No, that could be. I mean, look, the one thing that President Trump understands is that the price at the pharmacy is like the price at the pump used to be.
Yeah.
Drug prices are the new gas prices. And
except the price at the pump really is the real price. If we have $10 gas, if we had the comparison between.
Yeah, I'm not making a perfect analogy here. What I'm trying to say is it's a politically potent force.
Yes, right.
That the president.
People want to see the price.
Yeah. No, that's not what I'm saying. I'm saying people want to afford something they need.
Yes.
Like they afford gas.
Yes.
They want to be able to afford medication for their family.
Right.
And you know what the number one call to the American Cancer Society hotline is? The number one call is, I can't afford to have cancer. 1 out of 4 Americans goes to a pharmacy and doesn't fulfill the prescription because of price, according to the surveys. And in January and February, that's as high as 50% because people are in their deductible. Prescription drug prices we all need to live should not be subject to a deductible. I know that's a regulation. I know you don't like that, but it's a reality that people can't take care of themselves. That they will get sicker. So I think that Secretary Azar has put forward a series of good things that in Medicare Part B and Medicare D, they're all things that I support. They're all things that I think should be supported. I will say, I just came back from the UK. I spent time with the head of the National Health System. I asked him what they pay for a vial of insulin in the United Kingdom. Same vial of insulin, same plant, same factory. They pay 1/10 what we pay. So this is not about letting the free market do its job, because we've got multiple competitors of insulin in this country, and we pay 10 times what is paid in other countries. So there's something else that's not working, and even the proposals that Secretary Azar has put forward, they're not going to scratch the surface on those statistics I quoted you. They're not going to scratch the surface on people being able to afford medical care, and so we have to do something much more serious.
We'll be coming to the audience for questions in just a second. But first, how do you all see these debates shaping up on the campaign trails as we head toward 2020?
Yeah, I guess probably.
It's more on your side. There are a lot more candidates.
A lot more candidates, a lot of opinions. My perspective for the Democrats, and you can call this political advice if you want, is when the sky is gray, meaning when the President Trump and Republicans are trying to get the ACA overturned by declaring it unconstitutional, as we're doing in this case, it's coming out of Texas. When the sky is gray, don't spend all your time fighting over whether you think it should be royal blue or powder blue. Just kind of say it should be blue. In other words, Americans don't care as much as politicians think they do about how they get universal coverage. They don't care as much about whether it comes from the private sector or the public sector. And the reality is what they don't know, and Grace and Maria and I know well, is every single thing that gets done is through some hybrid combination of the public and private sector. There's a false dichotomy of saying this is public, this is private. There's nothing. The CMS has 6,000 employees. They run Medicare and Medicaid in $1 trillion budget with 6,000 employees. Of course they need the private sector. The private sector needs to be regulated. They have increasingly monopolized and become smaller and smaller and smaller as they've consolidated. They can't do that unless they're treated more and more like a utility in some form. So this question, if you look at all the countries in the world, you look at Australia, You look at countries like that, these are blended public-private systems where everybody gets covered, where the basic needs of people get taken off the table. I think that's where Democrats are likely to end up. And they're going to have a primary short-term battle over, is it Medicare for all, or is it this, or is it this, or is it this? But at the end of the day, I'm fairly confident Democrats will come out with a position that says, we think it's a right, we think the sky should be blue, they think the sky should be gray.
All right. Is there a question from the audience? This one over there. Yes.
Good morning. Questions for former acting administrator. I'm with the Medical Group Management Association. And with this move towards value-based care and talking about MIPS and APMs, what do you think Congress and CMS and CMMI could be doing to promote more new, better alternative payment approaches, alternative payment models, as opposed to fee-for-service? And then do you think that should be done in a voluntary fashion? Should you mandate participation in these models by physicians and medical groups? Just curious to hear your thoughts.
No, it's a great question, and the whole question of value-based care, at some level, it comes down to this. If you ask a hospital CEO who currently gets paid fee-for-service, they get paid based on how many tests they run or anything else, what would they do differently? How would their hospital system change if all of a sudden they were capitated, which means they just got paid a set fee for everybody in their community that came to their hospital and they had to manage the costs? You ask them the question, what percentage of your cost structure do you think you could take out of your hospital? Most CEOs will tell you that it's between a quarter and a third. So what that means is, to the point of the premise of the question, how we pay does matter. It's not the only thing. We have to actually have a culture of caring. We have to focus on social determinants and those sorts of things. But that does matter. So the question is, how quickly can you get there? It's not should you get there. It's how quickly can you get to something that's more like capitation or more like I'll pay or something like that. And the reality is, we've got to have models that continue to push people faster. And I think mandatory models make sense in places. I think Congress and the administration are going to have to work together on those things. Fortunately, I have not seen that as a polarized issue. When we were in the administration, we purposely did not ever talk about all of the value-based payment models as part of the ACA, which of course they are. But we didn't do that on purpose because we knew that the ACA was controversial. We wanted to leave this to be something that wouldn't be controversial, that Republicans and Democrats could own and work on together. And thankfully, I think they are.
And I actually think the value-based payment, I think the social determinants of health that Congresswoman Underwood talked about, there's a lot of support for those issues. And I think that may be something that may not get a lot of headlines,
I totally agree.
but progress that can be made over the next couple
Mental
of years
health,
because they're
opioids.
not. And opioids as well,
Yeah.
because there really aren't partisan issues. They're really
not.
trying to solve real problems,
Right,
and not make political
right.
points.
And if those things, and with people like you who have really great ideas, and others on the other side, if we debate those ideas, that's the kind of politics that's healthy.
That's right.
But if we do that with a goal that we all share, and we essentially don't let any one party own the issue.
Right.
If one party owns cost, one party owns coverage, one party owns mental health, one party owns values, one party owns social determinants, one party, that's destructive, because then the other party has to be against it. And so if we move to a place like we could make our politics healthier, I think we'll be much better off.
Just one last quick one. Do you think we'll be having the same discussion in 10 years? Do you have optimism?
Oh, I hope not. I really do hope we move to to a system where many more people have health insurance. There are more choices of health insurance that people can afford, that we've moved toward more coordinated care, more value-based care, and that the system has really matured to be able to figure out what works and what doesn't, and that we're spending money more efficiently.
I think it depends on what we do. Honestly, it depends on what all of you do. I mean, honestly, we do what we're currently doing. Congress does what it's currently doing. Yeah, we probably will have very similar sets of conversations. So we have to do things differently. We have to actually find those consensus points. We have to stop using divisive language that we know is inflammatory. I mean, you listen to how this conversation opened. We both agreed on the same thing, but we were unwilling to use the same language because we both have different ways of looking at it. But most importantly, we agreed on 90% of that message, which is that people should get the care they need. And so if we don't start building that way, I'm afraid we will not change. But I think we can.
Great, and I think we'll have to leave it right there. Thank you so much.
Susan.
Thank you.